Welcome so much to this session. Today we have the pleasure of introducing Dr. Sara Turbow to our session on GMN sites. I'm going to present her bio. Dr. Turbow, she's an associate professor of medicine and preventive medicine and a clinician educator investigator at Emory University School of Medicine. She completed her MD and MPH in epidemiology, then completed training in internal medicine primary care at Emory University. She has served as program director of Emory Public Health and General Preventive Medicine Residency and Fellowship Program since 2023. She's a health services researcher focusing on inter-hospital care fragmentation, health information technology, and aging and dementia. It's a great pleasure to have you, Sara, today talking about fragmentation of care in Alzheimer's, which is something that super interesting to everyone, especially to me. So thank you so much for giving this lecture. Go ahead, Sara.
It's my pleasure. Thanks for having me. As Gabby said, I'm going to talk to you guys today about care fragmentation in Alzheimer's disease. My only disclosure today is that I have received grant funding from Eli Lilly, and the bulk of my research that I'm going to describe today is funded by NIH, but I want to say that it's solely my responsibility and does not necessarily represent the official views of NIH. So in this talk, I'm going to give kind of a state-of-the-art overview about research focusing on care fragmentation with a particular focus on how it impacts older adults with Alzheimer's disease. And I'm going to highlight the work that I and others are doing to try to understand and begin to solve this challenge. So the specific learning objectives are to recognize the impact of interhospital care fragmentation, to discuss 3 reasons why care fragmentation may particularly impact older adults with Alzheimer's disease, and identify potential systems-level solutions to care fragmentation. So first, we'll get the definitions out of the way. What is care fragmentation? So care fragmentation can mean many different things to different people because there are just so many ways that care can be fragmented in our health system. Here's some kind of broad categories. So care can be fragmented between clinicians, so like a specialist and a PCP, or a PCP and a neurologist. Care can also be fragmented between institutions, like between 2 hospitals or between a hospital and an assisted living or a nursing facility. And finally, care can be fragmented between entities. So pertinent to this group, honestly, care can be fragmented between GMN and the PCP, right? I know we all work to prevent that, but that's one way that care can be fragmented. Care can also be fragmented between the healthcare system and social services, the carceral system, et cetera. So specifically, my research focuses on interhospital care fragmentation or fragmented readmissions. So just to kind of give a visual, at the top, you have a patient who's admitted to one hospital and then they're readmitted to a different hospital. And at the bottom, you have a patient who's admitted to one hospital and readmitted somewhere else. So this is interhospital care fragmentation or fragmented readmission, which I will use interchangeably. Interhospital care fragmentation can exist on a spectrum. So if you think about an admission to Emory and then a readmission to Emory University Hospital Midtown, that is fragmented, but it might be less fragmented than an admission to Emory and then an admission to the VA or a far-flung hospital in another part of Georgia that may not communicate well with Emory. So my interest in fragmentation really started when I was an internal medicine resident at Emory, because I would see the same patients at Grady, at Midtown, at EUH, and sometimes even at the VA. And it made me wonder if anybody was kind of tracking these patients or figuring out how this fragmented care impacted them. The impact of fragmented care was really driven home for me, however, when it impacted my family. So this is my paternal grandfather. We called him Pear. He lived an awesome life and passed away in 2019 at the age of 92. He had a lot of health challenges over the years, as many do, but the hospitalization where he passed away was actually really impacted by fragmented care and poor information exchange. So like many older adults, he was a snowbird. He spent half the year in Virginia Beach and half the year in Florida. But a little unique, he also got healthcare outside of those places. He was seen for many years by a pulmonologist at NIH. He was admitted for pneumonia at a hospital in Florida, and they could not get his records from either his Virginia doctors or from the NIH. And while my family was eventually able to get the care team in Florida his health records and the contact info for his physicians, he unfortunately developed complications from pneumonia and passed away in the hospital. So of course, I'll never know whether if they had had access to his records from day one, if that would have changed the outcome of his hospitalization. But I do know that it shouldn't be on the families to resolve these structural barriers to the flow of information between settings of care. So I'm willing to bet that every single person in this audience has had an experience with fragmented care, maybe as a provider, maybe as a patient, or as a healthcare leader. So if your personal or professional experience isn't enough to convince you that care fragmentation is important, I'm going to share 3 reasons with data to back them up why you should care. So first, here's some data about how common care fragmentation is. And that's reason number 1, care fragmentation is common. So the average US-based physician must coordinate with 229 other care providers across their patient panel. Another study found that a physician in an average sized urban hospital was connected, or the average physician in an average sized urban hospital was connected to 187 other physicians for every 100 Medicare patients they had. So it's a lot of fragmentation. So we have the first poll question. So I'm curious what the group thinks. What percent of 30-day readmissions are fragmented?
Okay, the poll was just launched, so waiting for
Yeah.
some responses.
Yeah. And it's totally okay if you don't know the answer. That's why I'm here.
Okay, we have about 46%. Can give it a few seconds. Okay, we have 61%.
Great.
And the poll and share the results.
All right. So 59% of people said 50%, 18% of people said 25 and 75%, and 6% said 10%. So that answer is actually 25%. So between 20 and 25% of 30-day readmissions occur at a different hospital than the admission hospital. So fully a quarter of readmissions are fragmented. So reason number 2 is that care fragmentation is bad for patients. So a few years ago, I had the pleasure of working with an internal medicine resident to do a systematic review of patient outcomes following fragmented readmissions. So I'll go over some of them at a high level. So interestingly, mortality was the most common outcome examined in these studies. And these studies observed between a 10% and 100% increase in in-hospital mortality. I want to highlight that these studies looked at very different populations, many of whom were quite sick. You can see that a lot of them, or several of them, looked at post-surgical patients, and some of them looked at broader patients samples, like this one looking at the nationally representative sample. I also want to highlight that none of them specifically looked at older adults or older adults with Alzheimer's disease. In the review, several studies also looked at post-discharge mortality and similarly found between a 10% increase to 3 times the odds of dying following the hospitalizations. These looked at really quite wide time ranges. So most of them were 30 days. One looked at 1 year mortality. One also looked at 9-year post-discharge mortality, which was kind of wild. But again, very disparate populations. But I do think that this suggests that there's a signal that even if you survive that fragmented readmission, that you're at increased risk for mortality in the days to weeks following it. So my research is, again, really focused on older adults and thinking about how fragmented care impacts them. So, and again, I have a specific focus on older adults with dementia. And the reason is that, if you or I had a fragmented readmission, right, we could transmit our medicines, our history, describe our symptoms accurately. And obviously, if somebody has cognitive impairment, that's going to be more challenging for them. And so I really hypothesized that fragmented readmissions might have that additive impact on folks with cognitive impairment, specifically Alzheimer's disease. And I also was very interested in expanding the outcomes that we look at in fragmented care to include those that are important to older adults. So in this study, I used Medicare data to look at discharge destination following fragmented readmissions among older adults. I did do some sub-analyses in older adults with Alzheimer's disease, but just going to kind of share the high-level results here. So again, looking at non-fragmented versus fragmented readmissions, and then these are the 3 discharge destinations that I'm going to highlight here. So, interestingly, we found that a fragmented readmission was associated with decreased odds of going to hospice, decreased odds of going home with home health, and significantly increased odds of of leaving against medical advice, over 64% increased odds. So I think, specifically the home with home health, I think that one was very interesting. I think a lot of patients would consider going home with home health a successful discharge, right, versus going to a facility or subacute rehab. And so it was very interesting to see that that was actually lower odds uh, if your care is fragmented. Also of importance to our patient population, fragmented readmissions have a longer length of stay in studies generally between a quarter of a day longer versus a day longer. Again, lots of heterogeneity in these patient populations, but I think this is really important for patients who are trying to decrease their length of stay just to get so we don't, have functional changes and things like that. And then also pertinent to our patient population, fragmented readmissions are associated with increased odds of subsequent admissions. So for our patients, fragmented readmission can result in less chance of going home with home health, longer length of stay, and more readmissions. All right, reason number 3. You should care about fragmented care because it might have solutions. So, I don't want this to be, yes, I don't want this to be all doom and gloom. So we're going to talk a little bit about some potential preventable parts of fragmented care and some solutions. So another study I did looked at the association between taking an ambulance to the hospital and fragmented readmission. So thinking upstream. And in this sample, about half the admissions used an ambulance. And we found a 38% increase in the odds of a fragmented readmission if an ambulance was used to get to the hospital. I also looked at the association between coming from a nursing home and fragmented readmissions. Interestingly, there was no difference in the outcome, whether the patient had AD or not. And I found that readmissions from a nursing home were 19% more likely to be fragmented. And I think this was very reflective of what I had seen in clinical practice. I think nursing homes often send patients to hospitals that are closer, might not be necessarily thinking about where they were hospitalized before. So again, these are upstream risk factors that are associated with more fragmented readmissions that might be setting patients up for those bad outcomes associated with fragmented readmissions. All right, so what about solutions? So another major focus of my research is investigating whether health information technology tools can be actually used to address that information discontinuity that is present when care is fragmented. I'll just share a brief story from IMC's, where I work, the Integrated Memory Care Clinic at Emory. So I had received a message in the patient portal from a patient's caregiver saying that the patient had fallen while on vacation and had suffered a brain bleed. She had scheduled follow-up CT scan for the patient at another hospital, not Emory Hospital, but that was closer to home, and wanted me to look at the CAT scan and see, if it made sense to restart her anticoagulants or wait or what we should do or if she needed more imaging. And so I was actually not only able to see the note from the hospital where she was seen when she fell and see the initial CAT scan. I was also able to see the follow-up CAT scan in the health information exchange. And so it really helped me to coordinate her care, make a plan for her, and not, have to just delay until I could get a fax from these outside facilities. So even though her care was fragmented, I was able to use the HIE to help coordinate her care. So I love this quote. It's from the Institute of Medicine. Connected care is the goal, disconnected care is the reality. And I'll add, our health information exchange is the solution. So what is a health information exchange? For those of you who aren't familiar, HIEs are electronic systems that share health information between settings of care. And I and many others hypothesize that one of the reasons for these poor patient outcomes we see when care is fragmented is that you don't have the information, right, about what happened at the previous admission, maybe what happened with their PCP, and HIEs can really bridge this information discontinuity. So my current work, here, I forgot there was another one. Okay, perfect. So we have our second of 2 poll questions. So I'm just curious in this audience how frequently you guys use health information exchanges to care for patients. And this can be something like Care Everywhere, GHIN, whatever, with the Georgia Memory Net Health Information Exchange, whichever one you guys use.
So the poll is launched and rating our responses. We have about 34% so far, and give it a couple of seconds.
And Sarah, this is a great question. Remember that providers in this chat, some work at Emory, Piedmont, and some
Yeah.
systems are connected and some are not. But we're
Oh,
getting
I am
there. But
familiar. Yeah.
when we have patients admitted to one of these places that are not connected through Care Everywhere, that's where we are starting to struggle and we lose
Yeah.
information.
Yes, absolutely. And I'll actually share some results of a study I did looking at just that. All right. So 50%, and I know that not everybody in here is a provider, so that makes sense that some of you also don't have access to HIE, but it seems like quite a range. So um, uh, of the 50% who have access to an HIE, most use it daily or multiple times a day, and then some weekly and some monthly. Great, great. Okay, so to Gabri's point, so just a little bit of data first. So I did a study where I looked at specifically among older adults with Alzheimer's disease, whether their hospital had a shared HIE or not with the admission hospital, whether that was associated with decreased in-hospital mortality. We actually found almost 40% decrease in in-hospital mortality when the admission and readmission hospital shared an HIE. There was no impact on post-discharge mortality. So again, signaling that kind of the benefit of HIE might end at discharge. Um, so um, to Gabby's also point, so I actually did a survey of inpatient internal medicine and emergency medicine clinicians all over the Atlanta area, and just want to share some results from that. And this was really about kind of how frequently they use HIE, what they're looking for in the HIE, and what the barriers are. And so in this figure, this is what they said about how frequently they access different types of information. And pertinent to this group, I want to highlight at the bottom the advanced directives. Less than once a day, obviously, most clinicians are accessing it. But when we ask about kind of attitudes and specific barriers, you can see at the bottom only 13% of respondents strongly agreed that they were able to access information on patients' advanced directives in the HIE. So I think, again, pertinent to this group, like that's a huge problem because as much as I would love for clinicians to access all the labs and imaging and not get repeat labs, to me, that's less of an issue than not being able to access something that could really pivotally change the course of someone's hospitalization, like an advanced directive. So I think that there's a lot of work to be done here and clearly a lot of barriers to overcome. And so
Sarah,
then,
going back to, there is a comment in the chat that
okay,
exactly what you're saying from Monica Parker, and she's saying that health information is not always accessible in different healthcare systems electronically, and that's
exactly.
the
Yeah.
point
So
here.
most, as you know, most hospitals in the Atlanta area are on Epic, with one notable exception, and then also the VA. And so I think, yeah, if you're able to access the info and care everywhere, it's pretty good. But if you don't have, if the hospital doesn't have care everywhere, they don't have Epic, it's really challenging. And then I also did a qualitative interview study where I interviewed 20 hospital and healthcare leaders around the Atlanta area, just as kind of a companion to my survey of the clinicians. And this is kind of the lay summary, just to share like the high level themes. So they found that HIE is definitely better than not having anything at all, but it still has a lot of problems. Interestingly, they felt that the policies both facilitated and threw up barriers to HIE use and implementation. The technology could create challenges and don't always work well together, as y'all know, and that HIE really needs to get better in the future. And they had a lot of ideas about how to share that. So I know that we flew through that. I'm happy to answer any questions. I do want to leave y'all with a couple of things to think about and take back to your practice or your workplace. If you do see patients, I think it's worth thinking about how you can ask your patients about fragmented care. This is something that maybe comes up in AWVs, right? When we ask our patients who are your other clinicians, but I think it's worth it to also think about, okay, are they within my system? Are they outside of my system? Can I access their outside health information? And then is there anything you can do to prevent or mitigate fragmented care in your practice? And so with that, I thank you so much for listening, and I'm happy to take any questions and comments.
See, Sarah, if you have any questions in the chat, this is a great presentation and kind of also focus on care fragmentation in dementia as an outpatient provider. And you see sometimes patients with so many comorbid conditions besides dementia. And again, to coordinate care for those patients is super important to be sure that everything we do is aligned with brain health and brain protection and not using any potential anticholinergic drugs, any benzos. And many times, and I see in my practice that care sometimes is not aligned to what the patient's preferences are, and it's not aligned based on the diagnosis of dementia. And you see maybe a patient with severe dementia who is attending 5 different other clinics, and each different clinic like focus on one disease, but this patient has multiple chronic conditions, including maybe moderate and severe dementia. So care sometimes is like, it has no sense, it's not aligned. So we see that a lot in doing outpatient. And for that, we have now these guide programs that are really helping. So that's good.
Yeah, so I'm one of my kind of new areas of focus is on outpatient fragmentation. So both kind of what is called ambulatory fragmentation, which is where care is shared between a PCP and one or more specialists, but also primary care fragmentation. So I worked with a medical student last year to do a project in using my Medicare data, and we found that like 16% of older adults in the broad data set, so not just with dementia, saw multiple PCPs. And so if you're thinking about whose job it is to own the med list, right, to prevent those anticholinergics and benzos and all that stuff from being prescribed or to deprescribe them if they are, and you're seeing multiple PCPs, like I feel like that's a recipe for disaster. So more to come. Maybe in a year or two, I can come back and share the results of that work. But I think it's really interesting and a real opportunity to improve patient safety.
Yeah, that's a good question. We have a comment again from Monica Parker. Thank you, Monica, for participating. And she's asking us, within Emory Geriatrics and integrated memory care, are we fixing this? Good question, Monica.
I think it's hard, right? No, I think is the short answer, right? You know, we're still in a very fragmented system. I think things are better, you know, with the HIE. You know, I have patients who live closer to Emory St. Joe's, for example. So if they need to go to the ER, they'll go there. And it's really nice to be able to kind of see all the results. Or if they go to Grady, you know, even a couple years ago, we couldn't see the results from Grady, right? And vice versa. So no, I don't think we're doing a good job to fix this. I think to Gabby's point, like, you know, we can try to defragment care by making sure patients are only seeing the specialists that they need to. I do talk to my patients if they have an admission about like, hey, if you need to go back to the hospital, like try to go to the same one, but it's not always in their control, especially if they call an ambulance. So the short answer, Dr. Parker, is no.
We have another comment from Ashley Varner, and she says, it seems like there is an intersection between those aging solo with MCI dementia and fragmented care. Is there research in this area? When there is an identified caregiver care partner, we can empower them and teach them about fragmented care, but when there is not, that's a challenge.
Yeah, great point. You know, I haven't seen research on folks aging solo with MCI or cognitive impairment and care fragmentation. I think that would be very interesting. Yeah, great question.
Yeah, great question. And we see this a lot. Patients coming to the memory clinic alone without the caregiver. It's really hard to establish a diagnosis. And that's why at Social Memory and the Max, we always ask them to come with a family member because to do the functional assessment, talking to the caregiver is like a fundamental piece to make the right diagnosis. So it's really
100%.
hard to do an assessment, like a memory assessment without a caregiver. But yeah, you're absolutely right. Yes.
Yeah.
Good question. Good point. I don't think we have, if we have any more questions, please put them in the chat. We still have another 5 minutes to talk about this. And
if anybody is interested in this, please email me. I'm always looking for collaboration, and would love to, you know, further engage with anyone who's interested in this area of focus. And there's
and Joanna is saying, great comment. We could examine that using GMN and Medicare data. Yes, definitely. That's a great point. Yes. Sarah, can you pass to the next slide so we have the next
Oh, yes, thank you.
demographic information? Please fill this information. Okay. We have a few more questions. Monica is asking, are there social workers in geriatrics on IMCC who can help? That's a great question. I can tell you, I can answer from Grady. So I'm part of the Grady Geriatric Clinic, and this is where we host our guide at Grady Clinic too. And yes, we have a social worker who it's really trained in geriatrics, and we try to provide more services and we try to decrease care fragmentation. But maybe Sarah, can you comment on the integrated memory care system and the social workers and care fragmentation?
Yeah, I mean, I think that when it comes up, Jenny, our incredible social worker, definitely addresses it. I don't think that it's like necessarily the forefront of everyone's mind, though, you know. I would say honestly, patients probably bring it up more, particularly around the issue of specialists. You know, do I need to keep seeing this specialist, that kind of thing, but not so much through like, oh, I want to defragment my care kind of lens.
Yeah, and there is a whole chapter in geriatrics, and this is like a hot topic now, living with multiple chronic conditions.
Yeah.
And that's when you have one patient with multiple chronic conditions like dementia, diabetes, CKD, CHA, like the patients we usually see in geriatric clinic, like which disease do you treat first? And of course, guidelines are really designed on one single disease, but the patients we see with the complexity in geriatrics, they have multiple chronic conditions and dementia. In my experience, what really helps is base care based on the staging of dementia. So you
Mhm.
really need to say what is the staging, because dementia is like saying CKD. You could have CKD 3A, and that's just one other condition, or you could have CKD stage 5 on dialysis, and that is going to change your whole management. So, in my experience, staging dementia correctly really helps to align care to what this patient and family really needs. So, that's just an
Yeah.
advice.
Yeah, that's great advice.
Good. And another comment is that another huge challenge of fragmentation is from inpatient and outpatient. Yeah, that's for
Yes.
sure. Definitely, yes. We have more comments and I can read them. And thank you so much for being so active. We really like this to be very interactive. So Ashley saying Emory has recently increased their case management department and dementia. It's a flag for telephone follow-up. But then there is fragmentation between the telephone case management department and the neurology and AMC social work departments. Yes, I can tell you what
Yes.
we do at Grady. We have 24-hour access, and we coordinate the phone line who answers the participants with dementia, the phone during the off hours with the day team. So by doing like secure chat, we really make sure that if they call during the night, we assess them and we address them during the day. But yeah, that's a challenge, definitely.
Yeah.
Excellent. Thank you so much. That was
My
super,
pleasure.
super interactive. Sarah, can you go through the next slides where we're going to introduce our next lecture? And this is September 16, and we're going to have Dr. Nathaniel Chin on why I started the Dementia Matter podcast. So this is like a different view, social media, and please join us next session, okay? I don't
Awesome.
know if we have any more comments. And yeah, one more slide, Sarah, so they can fill the QR code and get CME for attending this session today. Good. Any final comments, Sarah, on this?
No, just thanks everybody for your comments and questions. And like I said, please do get in touch if you're interested in this as a research or scholarship area. I'd love to collaborate. And thanks for all the comments. It gave me some cool stuff to think about.
Thank you. And thanks so much for the audience for attending this session. And we'll see you next month talking about the podcast. Thank you so much. Thank you.
All
Bye
right. Bye,
bye.
everybody.